Hello everyone. I'm going to discuss about my recent clinical experience. A 37-year-old male presented with left knee pain associated with repetitive kneeling related to the occupation in auto maintenance. He reported a previous fall involving the same knee, which had resolved without a medical treatment. The current episode persisted with swelling and knee pain during walking and kneeling. An X-ray was ordered by medical provider with a negative fracture or dislocation. During the physical therapy examination, the patient demonstrated a limited active and passive knee range of motion, as well as weakness of the knee flexor and extensor muscle with grade 3 out of 5 on MMT. Special tests were positive for McMurray and the Salis test, while anterior drawer test, posterior drawer test, Leishman's test, valgus and varus stress tests were negative. He also reported catching, locking, and clicking sensation with certain motions. The patient initially believed he had an ACL injury based on information he found online while Googling. The therapist provided education on knee anatomy and biomechanics and discussed the difference between ligamentous and meniscus injuries. After effective communication and review of the objective finding, the patient gained a clear understanding of his condition. Clinical examination findings were more consistent with meniscus injury rather than ACL tear. The therapist explained the gold standard for confirming the diagnosis would be MRI. An MRI was ordered, and while awaiting imaging, the patient began a physical therapy treatment. The treatment included strengthening of quadriceps muscle, knee flexor muscle, and calf musculature with active and passive range of motion exercises to improve flexibility, and education on proper body mechanics, gradual progression of activity, and home exercises was provided. After 4 sessions, improvement were not in both active and passive knee range of motion as well as strength. So he gained a good strength, and however, he had pain and clicking sensation persists. 2 weeks later, MRI was revealed a baggage handle meniscal tear with a full thickness longitudinal component. The patient was referred to an orthopedic specialist, and the treatment plan was modified. Due to the severity and mechanical nature of the tear, arthroscopic surgery was recommended. Conservative management was placed obviously on holding pending completion of postoperative rehabilitation protocol. Although there is no directly identical scenario outlined in ACR appropriateness criteria, I tried to search, however, I didn't find exactly same scenario, but the current systematic review and meta-analysis indicates that MRI demonstrate high sensitivity and specificity for diagnosing ACL and meniscus tear compared to other imaging modalities. MRI is particularly valuable for visualizing meniscus structure, tear pattern, vascular zone, and associated interarticular pathology, all of which are essential for determining the most appropriate management strategy. Thank you for listening. I will attach the reference on discussion post. Thank you.